So I wanted to make a brief video explaining why the difference between gonococcal urethritis and non-gonococcal urethritis is actually somewhat confusing to us in convenient care. So one of the providers and I were having a discussion about this, and we sort of went back and forth about what wasn't up to date, and I realized it was a good thing because we were actually arguing about what wasn't up to date, so we're using it as a common reference source. So what I'd like to point out is that the reason it's confusing about urethritis and up to date is the fact that there's a historical perspective they don't talk about. Right? So most STI clinics, right, back in the day, right, this person would come walking on in, right, they'd come to your little clinic, right, they would get tested, which actually basically looked at a microscope, which is a bad microscope. Based on what you saw under the microscope, they would then either be treated or not treated, and then go out the door, never to be seen again. So the distinction about this is that all the CDC data, all the public health data assumes that patients are unreliable for follow-up, and though the underlying principles are the same, the execution of those principles are different because our patients are reliable for follow-up. So you could see that if a person comes in and they have a urethritis, you want to see whether they have GC or chlamydia or perhaps something else or something that doesn't need to be treated. So you swab them underneath the microscope. You swab them, gram stain them, right? You look underneath the microscope, you're going to see a couple of things. If they have this sort of light pink diplococci in the middle of their cells, they're going to have GC. Right? If you look and you've got a barely pink single cellular organism, it's going to be chlamydia. These are all gram stains, right? Or essentially it's going to be clear. There's other possibilities, but for right now, that's what we're going to look at. So comes walking on in, come to our clinic, right? Take a swab, look at them underneath the microscope. Oh my God, sir, you have gonorrhea, right? So you'd be treated appropriately, which back in the day, believe it or not, was possibly penicillin. Or you got chlamydia, which could be treated with all sorts of stuff. They get treated, right? And they go basically walking out the door, and you can assume you're never going to see them again. That's not the case with our patients. Our patients are reliable for follow-up. So what happens with our patients is that they come on in, right? We know that, and we get rid of all this stuff. And what we're doing is a little bit different because we know they're reliable for follow-up. If they're not reliable for follow-up, we treat them like this. But since the vast majority of them are, we don't treat them like that. For our folks, they come back on in, and so they walk in the door. They have a little bit of drip and a discharge. We test them. So we get a urine from them. We send the urine off to the lab. Right? They leave our clinic. They leave convenient care, and they go home. Waiting. Wanting to know what their test results are. Then, once we have the test results, if they're negative, we don't really call them. We do if we want to, because that's a particularly nice thing to do, but we don't have to. If they're positive, we actually do have to call them. All right, so the urine comes back, and it's either going to be clean, it's going to be positive for GC, or positive for chlamydia, or positive for both. Then they come on back, and if they're positive for GC, we can give them ceftriaxone. And if they're positive for chlamydia, then we give them either azithromycin or doxy. So historically, I just want to point this out because it's a little confusing, right? We're going to build a four-part structure, and we're going to point out why this is relatively irrelevant for our patients. Then in the next video, we'll discuss a nice structure that we can look at that makes more sense for our patients. So let me get rid of this. So what's going to follow is the structure that up-to-date suggests, but again, the underlying assumption is none of those patients are reliable for follow-up. Okay, so we're going to use a four-part structure. The first part is that we're going to use the anatomy. From there, we're going to use the source. And then we're going to look at the bacteria, which will be right there, and then we're going to look at the appropriate antibiotics. Okay, so obviously the source is urethra and it's affected, so it's going to be urethritis. Now, they make the distinction and they say, well, there's actually two kinds of urethritis. There's gonococcal and there's non-gonococcal. Keep in mind, in order to say that, you actually need to have a microscope, right? You cannot distinguish without testing. Or you need to have NAAT going on, right? Which you need this. In our case, keep in mind, we don't use a microscope. Right? We can't distinguish without testing, so if they're lost for follow-up, we're going to treat them for both. So let's develop the structure a little bit further. So as far as non-gonococcal or gonococcal urethritis, right, we know that the bacteria for gonococcal urethritis is actually gonorrhea. Non-gonococcal urethritis is going to be chlamydia. Now the antibiotics are relatively straightforward. For gonorrhea, they're going to get ceftriaxone. And for chlamydia, they're either going to get doxy or azithromycin. Now, this whole structure assumes that these patients are not reliable for follow-up. So let's just say a small percentage of our patients are not reliable for follow-up. Somebody comes into our clinic, they have urethritis, and they're leaving off to go back to wherever they came from, and we're never going to see them again, right? Well, they're unreliable. So in this case, right, testing won't come back. We certainly don't have a microscope, but most importantly, you cannot make the distinction without testing. So if somebody comes in who's not reliable for follow-up, you got to treat them for both gonorrhea and chlamydia. So either way, you can give them ceftriaxone plus doxy, or you can give them ceftriaxone plus erythromycin, but under no circumstances what you can do if they don't have follow-up, you can't simply say, well, I'm just going to give you doxy or I'm just going to give you erythromycin. You can't do that. Because they're indistinguishable, you have to treat for both gonorrhea and chlamydia. This only applies to patients that are not reliable. Right? If we had a microscope and we wanted to go back to old-timey stuff, I suppose we could look at it, but nobody really wants to do that. So just keep in mind, the whole point about this is that if they're not reliable for follow-up and you're going to treat them, then you need to treat them for both. If they are reliable for follow-up, then you don't really have to treat them at all until our testing comes back. Now, what I'm going to suggest to you is there's actually a better way to set up your structure that makes more understanding relevant to our situation. So let me get all this stuff out of here. That